quality improvement work. So today we're here to talk to you about Superior Health Quality Alliance. We are your Quinn QIO. So next slide. So a little bit about who we are for those who might be brand new to us. Superior Health Quality Alliance is a collaborative of 8 organizations across 4 states, and we include those following members that you can see on that wheel there. We're 4 state hospital associations, 3 technical quality improvement organizations, and 1 ESRD network. So all of those combine to make Superior Health. And this time around, because we've expanded, which I'll walk into a little bit, we also work with QSource, who has a long history as the Quinn QIO in Indiana, and they're an essential part of our work. Next slide, please. So we have a great deal of experience on our team. Our members have decades of experience improving quality and safety across the continuum of care on a wide variety of topics and programs that you'll see right there on the screen. We've worked on over 25 contracts and programs, and we're looking forward to working with all of you again on our Quinn QIO work. Next slide. So the Quinn QIO program was established in 1982 under the Social Security Act, and it's a federal initiative to improve the quality of healthcare for Medicare beneficiaries. I always like to remind people that we are non-regulatory, and we're really here to provide education, resources, and technical assistance to nursing homes, hospitals, and clinics. And those of you who maybe worked with us, let's say a year ago, if you haven't talked to our team again this year, you'll definitely want to do that because it is time to re-enroll. That's what we're coming back around to do, is that these contracts last about 5 years. And after those 5 years are over, we get a new contract with new goals and focus areas as deemed by CMS to work with nursing homes, hospitals, and clinics on some of those areas. So if you haven't talked to someone on our team, and I can always check with you to let you know if you're enrolled, but if you haven't done so within the past several months, you may need to re-enroll in our work. So next slide, please. And that work is now called the 13th Scope of Work. So the Quinn QIO program has evolved over time to meet the changing needs of Medicare beneficiaries and their providers across the continuum of care. And in June of 2025, CMS launched the 13th Scope of Work to support healthcare quality improvement in the Secretary's Make America Healthy Again initiative. This is one of the largest federally funded quality improvement programs in the country, and CMS directs quality improvement organizations to collaborate with healthcare providers nationwide to improve outcomes for Medicare beneficiaries. So while the program started in June of 2025, we started reaching out to facilities back in October. So that would kind of been when you might have started to hear from our team. And if you haven't talked with us since October, it might be time to reach back out. So next slide, please. So the other big change that happened with this 13th Scope of Work is that the regions have changed. Luckily, Michigan is still here with Superior Health Quality Alliance, but we've expanded. We used to work with Michigan, Minnesota, and Wisconsin, but now we're working with those 3 states as well as Ohio, Indiana, and Illinois. So we've expanded from 3 states to 6 states, but we're still the great quality of experts that you've worked with in the past. Next slide, please. And this is kind of more so for some of the other states that we've worked with, but you can see here that as we've expanded, some of those other states have worked with other Quinn QIOs in the past, but now they'll get to work with our team and we'll all get to learn from each other. So there's great opportunities on our calls that you'll hear from some best practices from nursing homes in Indiana that you maybe have never heard of. And it's really great to have this wider expanse of a region so that we can share more things on that wider scale. Next slide, please. So as I mentioned, this is a 5-year contract. So the 5-year Quinn QIO program will focus on a state-based landscape for the first 12 months, engagement of provider organizations, initial assessments, and development of quality action plans. And we're currently in year 1 or those initial 12 months. We have kicked off our partner engagement where we are reaching out to facilities that we have known contacts for. For the states that are new to us, we're working to get their contacts for those organizations. So if you're part of a larger corporation, we'd love to work with your whole corporation as well. So you can always feel free to pass our information along to any of your corporate leaders and get them in contact with us as well. Some organizations have already received enrollment information via email, and we're also making calls and sending emails to other organizations to get contact information or to get those enrollment forms over to you. We also completed state level A3C modeling, which is modeling of what's out there in the state already to support and provide assistance to providers. In an effort not to duplicate work, we are collaborating with organizations to improve quality outcomes, and Superior Health is engaging with healthcare organizations and providers that have been identified as having opportunities to strengthen care and patient outcomes. In years 2 through 5, we'll be providing technical assistance tailored to the needs of each participant and support them with improvement interventions, measurement, and progress reporting. And together, we'll complete a facility assessment and identify areas the organization could work on given the identified needs of the facility. So what that means is you just talk with one of our team members on at least annual basis and say, these are the things that are most important to our organization, and we'll help you achieve your goals. And in the final months of year 5, we'll wrap up the work, we'll celebrate the successes, and we'll make a plan for a transition as needed and provide those final outcomes. And the 13th scope of work provides support from May 2025 through May 27th of 2030. Next slide, please. Now, these are the broad focus areas that were provided to QuinnQIOs for the 13th scope of work. So disease prevention and chronic disease management, patient safety, behavioral health, care coordination, and then these overarching ones of emergency preparedness and workforce challenges. Next slide, please. Getting in a little bit more on a couple of those more quality management infrastructure, those foundational aims, that emergency preparedness. For this, the QMI emphasizes emergency preparedness to ensure healthcare systems respond effectively to public health crises. So for example, when the COVID outbreak started, really making sure that everyone has what they need in order to more effectively navigate those emergencies. So things that we often help with are tabletop exercises for emergency preparedness, maybe looking at cybersecurity, things like that. Workforce and governance, so strategic workforce planning and governance structures enable sustainable and quality healthcare delivery. Technology and innovation, so integration of technology and innovation reduces burden and enhances care quality and delivery. And then supply chain and safety, so managing supply chains, drug shortages, and cybersecurity strengthens safety and quality in healthcare systems. So these are all the aims that we're really focused on across all organizations, because if we have these built up, it really helps for that firm foundation to really improve all of the other areas as well. Next slide, please. And then those clinical aims that you saw on that first slide as well. So prevention and chronic disease management. So things that we've really worked on in the past, like increasing vaccination rates, helping with chronic diseases like type 2 diabetes, hypertension, and chronic kidney disease. For patient safety initiatives, so reducing infections, adverse drug events, things like falls and pressure injuries. Behavioral health strategies, so addressing depression, suicide prevention, substance use disorders, and chronic pain management. And then care coordination efforts. So historically, we've always helped with reducing hospital readmissions and emergency visits by improving care transitions and integrating social services. So those are the broad aims that we're going to be focused on through our work here at Superior Health. But again, our goal would be to sit down with your team and have you tell us what you're most interested in so that we can really help you focus on those goals and design the resources that you might need in order to make those improvements. And with that, I believe I'll be handing it over to my colleague, Amy, to cover more specific things that we can help nursing homes with.
Great. Thank you, Elena. So for the next few slides, I'm going to just share some information regarding what we provide to our providers, but I also want to just kind of share some of the work that we've already completed. And if you participated with Superior Health in the past, you are actually going to be like part of some of those accomplishments that we've achieved. So as a continuation of the information that was provided by Elena, here at Superior Health, our goal is to support facilities in achieving measurable improvements. And we want to sustain high quality care. So while providing comprehensive technical assistance, as Elena had mentioned, we also complement that by providing guidance from a designated quality improvement advisor. The support has spanned across several critical areas, which were briefly mentioned in the previous slides, specific to those clinical aims. However, some of those achievements that we want to share with you that we've accomplished over the last scope of work are some of these examples. So in regards to psychotropic medications and strategies, so Superior Health offered guidance on updating emergency plans and facilitated tabletops, as Elaine had mentioned. Also exercises for participating facilities. We performed on-site in regards to the psychotropic, So for psychotropic, we provided support in reviewing and developing reduction plans to minimize psychotropic and antipsychotic use in skilled nursing facilities. In regards to emergency preparedness, Superior Health offered guidance in updating emergency plans, and we facilitated those tabletops. One thing that we performed, especially with emergency preparedness, that was very beneficial for our providers is we offered fit testing, and we provided fit test train the trainer course. And this was to promote sustainability and compliance. And this is something that we offered towards the end of the 12th scope of work. And I actually was a part of initiating that train the trainer course. And we found it was very beneficial. It was much needed. In regards to that train the trainer, we had respiratory therapists, administrators, director of nursing, infection preventionists. So we had multiple team members that were involved in that learning, the fit testing. We also, for our quality assurance and performance QAPI program, we supported our providers by providing education, training, and assistance to enhance and assist improving a facility's overall QAPI program. And we accomplished this by providing one-on-one assistance to our providers, as well as we developed a 6-week QAPI basics session, and these were actually provided for lunch and learns. Trying to move my screen, it won't go, I'm sorry. There. So part of our rapid technical assistance, so this is something new for the 13 scope of work. In addition to ongoing technical assistance, in the 13 scope of work, the FQS offers a rapid technical assistance. So this provides fast, targeted interventions that are actually designed to address urgent quality and safety challenges. And those are the key there, urgent, and they have to be quick. So while delivering focused time, limited support to facilities, so we can quickly resolve those urgent issues and implement action improvements. And some of those rapid technical assistant initiatives that we will provide are quality improvement sprints. And so these could actually include just like 30-day durations, as well as one-on-one on-site visits. And this would be with a quality improvement advisor or through virtual assistants. We offer a focused quality process, and this actually involves identifying a root cause analysis, identifying what is the root cause to the problem, and then implementing a quality action plan that includes routine auditing, validating compliance, and then we help the provider develop a plan of sustainability. Along with our rapid technical assistance, we also have the results can be based on self-referrals. So if a facility identifies that they need some technical assistance, maybe it's a result of a deficiency or a plan of correction, they can reach out to us, and a quality improvement advisor would help that provider. We also can provide technical assistance if there's an emergency preparedness need, if you have an outbreak, such as like we had COVID in the past, or it could be a CMS referral. So if CMS identifies that there's a need that a quality action plan is needed or additional support is warranted, they actually will reach out to us, and then we would reach out to that provider. I can tell you that we have just started the 13th scope of work. However, we have had 5 actually FQS self-referrals for nursing homes. And we've actually had quality improvement advisors in helping those providers, and those were based on plan of corrections. In addition to the rapid technical assistance, we actually have what we call the beneficiary and family-centered care program. And so this may not so much be a rapid technical assistance program. You probably maybe have heard of this. So in the event a Medicare beneficiary or a patient or resident or the beneficiary's representative has a quality of care concern or complaint with their care, they can actually reach out and file a complaint to their beneficiary and family-centered care quality improvement organization. And so then what happens is a peer review is completed, and then based on the findings, if a quality care concern exists, then that case is referred to Superior Health, and then a quality improvement advisor such as myself would actually review the case, provide technical assistance. With BFCCs, these actually have longer durations, and they actually focus more on systemic problems. So you may have had us reach out to you regarding a BFCC, and again, it's based on more of a systemic problem, more so than needing some rapid improvement or improvements based on urgent need. So the question that we're often asked is, what can a QUIN or QIO do for you? That is a very common question. So it's important to understand that with QUIN QIOs and the work that we do, it's non-regulatory, it's non-punitive, it's all support for quality improvement. We just want to improve outcomes for you and your residents and your staff. So QUIN QIO support healthcare providers by improving patient and resident outcomes while meeting CMS quality measures and enhancing operational performance. And actually, this is a no-cost service. So we don't charge for our services. It's something that we want to do and we want to help. 13 scope of work actually will focus on one-on-one technical assistance. And what's different about the 13 scope of work versus the 12 scope of work, we are actually functioning at a more broader scope, meaning so we're not just singled out to, let's say, skilled nursing facilities, long-term care. We actually now provide technical assistance to skilled nursing facilities, hospitals, and primary care physicians and clinics. The technical assistance that we provide will consist of Superior Health providing training resources, data analysis, health information, technology tools, coaching, instructor collaboration, focusing on the key priorities, again, in those specific areas that I talked about. And if you worked with us in the past, you probably have received some of the support. In addition, as part of the 13 scope of work, Superior Health has the ability to connect with facilities within local, state, and national resources and initiatives to support quality improvement efforts. So we have connections, and we can collaborate with community care collaborations, as well as maybe there's some type of prevention program that a facility may need, or based on a community-based organization. So those are just some of the resources that we can also help with. Now, if you have worked with us in the past, you may be familiar with some of our developed resources that we have created here at Superior Health. As stated, these are offered to our providers that sign with us. They're very beneficial, they're very helpful. If you have not signed with us or you have not participated with us, we will provide you with these links because we want you to just take a look to see what we have provided in the past, and you may find some of the information that we do provide helpful. Some of those resources that you will find are developed and supported by current standards of practice. They are aligned with national standards, and all content is reviewed and created by respected subject matter experts. So we will share, again, these links in the chat, but I just want to give you a brief overview of just kind of like what you'd find in each of these. So in regards to the Superior Health Online Resource Library, I encourage you all to take a look at this. This resource actually provides a robust selection of resources. Some examples that you would find in this library include antibiotic stewardship, health equity, vaccinations, person and family engagement, workforce solutions. You might find content around diabetes care, as well as blood pressure monitoring. We have videos, and then the content actually is tailored around various settings. So you will find information that's affiliated with hospitals, clinics, long-term care, home health, dialysis, and patients and families. And these are just touch the surface. We also provide our frontline forces. And so this is actually a series. And so our frontline forces actually exist to equip and support and empower our frontline healthcare workers. We provide tools, training, and resources needed to improve quality, safety, and outcomes for patients and residents. Each of our frontline force modules is developed with the novice to the proficient direct care staff member in mind. And some of our frontline forces that we've created include injection safety. This is a 3-part series. There's caregiver well-being, Legionella, MDS coding, and then behavioral interventions for people with dementia. For today's presentation, we will provide a link to our frontline force training module that is very specific around regarding change in condition. In addition, we have our toolkits for interventions. And so this link will also be provided. The one that we're providing today is a link to create sustained change in assessment. This resource is a part of another series, so if you're looking to make any type of sustainable change within your organization, you may find this particular resource helpful. Nationally, the Superior Health QIO program partners with leading organizations such as Centers for Disease Control and Prevention, as well as the Agency for Healthcare Research and Quality. Through our strategic partnership with state and local health departments and tribal agencies and other community organizations, Superior Health has actually has been driven to collect learning improvement collaboratives that partner engagement to enhance health outcomes, as well as operational performance, along with leveraging collective work, expertise, and provide engagement and support with our participants. So with a part of Superior Health and with our services that we provide, we continue to create positive impact across the continuum of healthcare. Superior Health was selected for our strong performance history and innovative approach to delivery, person-centered care, and data-driven improvement strategies. In the last 5 years, you will see that some of our improvements are very significant and our milestones are achieved, and these are just within the states of Michigan, Minnesota, and Wisconsin. And some of those achievements include 86% reductions in infection control citations among long-term care facilities. And with our support, facilities were able to avoid more than 270,000 patient harms. We were able to reduce hospital readmissions by 21%, and that we delivered more than $1 billion in measurable value. So those are fantastic milestones for our team. In addition, we're also going to provide the link to our Superior Health Transforming Healthcare Delivery Report. Again, I encourage you to take a look at this. In this report, you will actually find some of our shared outcomes as well as Superior Health contributions. And you will find the additional work that we have accomplished over our last scope of work. To demonstrate Superior Health's ability to deliver results across the full scope of work, this section actually highlights some of our key accomplishments and outcomes achieved during the 12th scope of work. And if you partnered with us in the 12th scope of work, you probably are part of these great percentages that you'll see in our improvements. These outcomes showcase Superior Health in executing complex initiatives, achieving measurable improvements, and partnering effectively to meet performance, quality, and equity objectives. So out of the 903 facilities, there was an 86% reduction in the F880 infection tag for citations. So that's infection control and infection prevention and control. And then in the fiscal year 2024, you're going to see for F88 citations that relates to the COVID-19 immunizations, there actually was 100% reduction in 100% reduction in those citations among our nursing homes. We also had high-risk nursing homes that received ongoing in-person infection control education and support, and they experienced a 25% reduction in citations. And then a total of 400 facilities engaged in our infection prevention affinity series. And this actually included 125 infection preventionists who received direct hands-on training from our quality improvement advisors. All attendees, that's 100% of those that attended, reported that the education was relevant and directly applicable to our daily work and responsibilities. Another resource that we had provided for our infection preventionists, so we developed an infection prevention 6-week series. So for facilities that maybe had a new infection preventionist or somebody new to the role, they attended these 6-week sessions, and we touched on topics that were important and that we found, speaking to our providers, what they found was important for infection preventionists to know. So we actually incorporated that into our learning. And then here are some examples that you'll find the impact on our CMS nursing home quality measures with the support of Superior Health. So additional outcomes associated with specific quality measures and the corresponding data, these were actually achieved through the 12th scope of work. So you see with pressure ulcers, with the support of Superior Health, there was a reduction by 31%. Staff vaccination rates, we actually saw a 21% improvement increase with support from Superior Health. So it went from 72 to 93% compliance. Unplanned hospital readmissions with the support of Superior Health reduced by 23%, falls with major injuries reduced by 35%, and then you'll see with the CMS quality star rating, before partnership with Superior Health, it was 2.7, and at the end of the scope of work, we had an increase by 0.8, so facilities actually rose to 3.5 stars. So these outcomes actually demonstrate measurable improvements across key quality indicators following engagement with Superior Health. Now, having reviewed the program's outcomes and the results of Superior Health initiatives, the next step is to focus on what is actually the nature of the technical assistance that we provide. And we touched base on some of those. Those that choose to partner with Superior Health will actually sign a participation agreement, and that outlines the benefits and expectations for both parties. And then all organizations, facilities, and providers will be assigned a quality improvement advisor. So if you participate with Superior Health, you will be assigned a quality improvement advisor, and this is your point of contact. This is the person that you reach out to, who will provide you the resources and provide any outreach that is needed. They will complete an initial performance assessment on those aims that Elena had talked about, and then develop a quality action plan to make improvements if improvements are needed. Again, we are about partnership. We work alongside our providers, and so we are here to support and guide you. That is our goal and that is our role. Alongside a and it's something that we're proud to share with our partners, is our Award of Excellence program. And this initiative allows us to celebrate and reward your hard work. So at the end of the scope of work, we recognize your hard work and dedication and outstanding achievements. This is an esteemed award that recognizes providers and organizations that demonstrate excellence in performance, as well as high quality care and strong commitment to continuous improvement. So recipients will be honored at an invitation only ceremony. And I can tell you from a quality improvement advisor, it just brings me great joy when I either deliver the award or we attend the award ceremony to see all the hard work actually come to fruition and just be able to celebrate that with you. And so in regards to the awards, some of those areas that we focus on are behavioral health outcomes, patient safety, chronic disease self-management.
I'll send it to you. Yeah. Okay.
We might have lost Amy, so I can take over. So really quickly, the Awards of Excellence program you're all likely very familiar with. Oh, she might be back.
Oh, I'm back. Can you hear me now?
Yep. And Amy, we
Okay.
might have to rush through these a little bit because I know their agenda is really full.
Yep, I'm almost done. So as part of the Excellent Award, enrollment is upon joining the 13 Scope of Work. So you join 13 Scope of Work, you're automatically enrolled. It does encourage evidence-based quality improvement aligned with CMS priorities. Participants must meet rigorous improvement milestones, and those are actually monitored and assessed by our data analytics that are conducted through evaluations to measure progress and effectiveness. So the next steps, and so if you have already enrolled, we are excited that you are with us. If you have any interest, if you want to enroll, we will put the enrollment form link into our chats. If you would want more information regarding how to join, Elena and I will put our email addresses in the chat, and you can please reach out to us. We'd be more than happy to provide you with any information you need or answer any questions you have. We do ask that if you want information from emails from Superior Health, make sure you just let your IT staff know to put us on your safe list so our emails don't bounce back. So we're finding that we're reaching out to providers and the emails are bouncing back to us. And then we are going to provide you with some additional resources, the quality net that we often use. the CMS conference is coming up in March 16th through the 18th. I encourage you, if you don't attend, you can attend virtually. The enrollment opened virtually on Tuesday, so you can go ahead and enroll if you want to enroll for that. We have our quality improvement organization link that we'll provide, as well as we'll provide the link about more information regarding the 13th scope of work and then our BFCC work. And that's it for our presentation. If you have any questions, just please feel free to reach out.
Thank you both. I do see some hands up, and I'm not sure if they're up for questions or if they're just left over from raising their hand that they've participated with Superior Health before. So if your hand's up and you have a question, go ahead and leave it up or ask your question. If not, go ahead and take your hand down. Looks like Vince may have a question. No, can't hear you if you're talking. How about Maureen? Maybe they're just left over. Maureen, if you're talking, we can't hear you.
And if anyone thinks of anything, you can pop it in the chat and we can always answer questions via chat, or you can send us an email. I listed both Amy and my email in the chat as well. So please feel free to reach out, and I'm sure we'll be reaching out to your facility soon. So thanks, everyone.
Thank you.
And their information will be shared with me, and I will post it on our website, so it'll be available after this meeting as well. So again, thank you both. Greatly appreciate it. Yes, the slides will be shared. All right, our next guest is actually the two assistant long-term care ombudsman for the state of Michigan, Anna and Michelle. Are you guys on and ready to take over?
Hi, Dave. This is Anna Hayes, and I will be doing the presentation, hopefully, if I can figure out Teams. So I'm going to give it a shot to get my PowerPoint up. All right, I'm going to keep fiddling with it a little bit. I think I have to start it in a slideshow.
Well, we can see it. That's for sure.
Do you see it as like an entire?
It's full. Yeah, it's a full slide.
It's a full slide at this point?
Correct.
Okay, is it still a full slide? Because now I can't see you all.
Yeah, it is.
Okay. Perfect. Well, oops. And it's wanting to go by itself. So again, my name is Anna Hayes, and I am an assistant to the state long-term care ombudsman. And yes, Michelle Danow is also in this call, and she is also an assistant state long-term care ombudsman. I do believe that Sally Pong is here, who you all may already know. She is our state ombudsman. And we're going to talk a little bit about who we are and how we serve nursing home residents today. And I'm happy to take questions at the end. And also, I wanted to say, since Superior Health said it, I won't be able to see you all, but if you've worked with the long-term care ombudsman program in the past, I'd love to see your hands up, just a show of hands who's worked with us previously. At the end of this session, we'd like you to know the history of the long-term care ombudsman program, federal and state rules and regulations which authorize our program, as well as program requirements, the services provided by our program, and our approach to resident-driven advocacy. We're going to start with our program history. The program started in Michigan in 1972 as a demonstration program under President Nixon's 8-point initiative to improve nursing home care. Michigan was one of 5 states to participate in the demonstration. And today, the long-term care ombudsman programs operate in all states, District of Columbia, Puerto Rico, and Guam under the authorization of the Older Americans Act. Each state has an office of the state long-term care ombudsman headed by a full-time state ombudsman. The Administration of Community Living, or ACL, implemented the initial federal long-term care ombudsman program regulations in 2016.
I hate to interrupt, but I don't think your slides are forwarded in the presentation or in the.
Oh, goodness. I was wondering about that. Okay, so I have a question. Tell me if it's moving now. Did it go back to program history or no?
Nope, we're still on we can only see the first slide.
So we do not use Teams.
That's fine.
At all. So I honestly am not quite sure. Does anyone have an idea of, I guess, what I could do? How about that?
Oh, there we go. There you go.
Does that work? And then do you see, thanks everybody for the help. All right. Can you just see the slide or do you see the notes too?
Nope, just a slide.
Oh, that's wonderful. Okay. Thank you. I was going off my PowerPoint screen, so I appreciate everyone letting me know. All right. I need to get the chat out of here. So long-term care ombudsman programs can be structured differently at the state level. And here we're looking at Michigan structure with the ACL, HHS. Since 2016, MDHHS contacts with the Michigan Advocacy Program MAP to host the state office of the Long-Term Care Ombudsman Program. I know I lost a little bit of time, so I'm going to try to go a little bit more quickly through here. Under the Older Michiganians Act, federal and state long-term care ombudsman program funds flow to the AAAs for delivery of local ombudsman services. State long-term care ombudsman is responsible for programmatic oversight of the local ombudsman program. So that's paid and volunteers. The host agencies, the AAAs and the subcontractors, are responsible for personnel oversight of local ombudsmen, both paid and volunteers. Long-term care ombudsman programs are authorized under the Older Americans Act and in Michigan under the Older Michiganians Act. Like nursing homes, we also have federal regulations for long-term care ombudsman programs, which further clarify the requirements of the OAA to ensure consistency in service delivery. That's referenced on the slide. So let's take a minute to look at access. We field a lot of questions regarding access. The federal regulations address access for the state ombudsman and any person designated by the state ombudsman to have access to enter all long-term care facilities at any time during a facility's regular business hours or regular visiting hours, and at any other time when access may be required by the circumstances to be investigated. We have access to all residents to perform the functions and duties set forth in section 1324.13 and 1324.19. Access to the name and contact information of the resident representative, if any, where needed to perform the functions and duties set forth in the same sections. more on access. We have access to review the medical, social, and other records relating to a resident if the resident or resident rep communicates informed consent to the access, and consent is given in writing or through the use of auxiliary aids and services. Titch closer. The resident or resident representative communicates informed consent orally, visually, or through the use of auxiliary aids and services, and such consent is documented contemporaneously by a representative of the office in accordance with such procedures. When we're saying representative of the office, I don't think we defined that, but that's talking about an ombudsman. The resident is unable to communicate consent to the review and has no legal representative, and the representative of the office obtains approval of the ombudsman, Sally, or access is necessary in order to investigate a complaint. The resident representative refuses to consent to the access. A representative of the office has reasonable cause to believe that the resident representative is not acting in the best interest of the resident, and the representative of the office obtains the approval of the ombudsman. We have access to the administrative records, policies, and documents to which the residents have or the general public has access of long-term care facilities. Access of the ombudsman to, and upon request, copies of all licensing and certification records maintained by the state with respect to long-term care facilities, and access to a list of resident names and room numbers. We are often asked about HIPAA and the long-term care ombudsman. The federal regulations indicated that HIPAA does not preclude release of PHI or other resident identifying information to the ombudsman program, as the ombudsman program is an oversight agency. The regulations identify the functions of the ombudsman program, which include to identify, investigate, and resolve complaints that are made by or on behalf of residents and relate to action, inaction, or decisions that may adversely affect the health, safety, welfare, or rights of residents. Provide services to protect the health, safety, welfare, and rights of the residents. Inform residents about means of obtaining services provided by the ombudsman program. Ensure that residents have regular and timely access to the services provided through the program, and that residents and complainants receive timely responses from representatives of the office to requests for information and complaints. In Michigan, the long-term care ombudsman program serves residents in nursing homes, licensed homes for the aged, and adult foster care homes. Currently, we have nearly 105,000 beds in over 4,700 homes. We do not have authority to access residents in non-licensed settings. Who does the work in Michigan? Currently, we have 40 paid ombudsmen and 10 volunteers across the state. Several AAAs are working on volunteer recruitment as we speak. Michelle and I are actually beginning a round of volunteer designation training on Monday. So we will be hopefully adding 6 more volunteers in the very near future. There are 7 staff in the state office whom offer support to those local and volunteer ombudsmen. Monitor service delivery and lead advocacy efforts at the state and national levels. Are my slides still going forward?
They are, yes.
Okay, perfect. In order to serve as an ombudsman, candidates must pass a 4-point background check, screen for potential conflicts of interest and remedy conflict if necessary, complete a minimum of 38 hours of training and mentoring. There's self-study, which is a minimum of 8 hours, classroom instruction, and which is a minimum of 20 hours, mentoring out in the field, which is a minimum of 10 hours. Our ombudsmen typically continue mentoring for 3 to 4 months after they are designated. They receive ongoing case consultation after designation. And we need to complete 18 hours of education each fiscal year. In Michigan, paid ombudsmen receive closer to 100 hours of training and mentoring before being designated. So what does an ombudsman do? We conduct regular visits to homes. We investigate and work to resolve concerns brought before the program. We provide information and assistance. We respond to notices of involuntary discharge. We attend resident care planning meetings, provide training on long-term care topics, participate in health or senior fairs, provide feedback to surveyors prior to a recertification survey, and we record all of this in our ombudsman database. What makes us different? Knowing the answer to this question may help others understand our unique role as resident advocates. Please note the words in green as I go through these. We start with the resident, always, regardless of complaint source or the resident's reported capacity level. We must have resident consent to take action to investigate a concern brought before the program. We investigate concerns at the direction of the resident. We work toward the resolution the resident is seeking. We must keep residents' and complainants' identity confidential, and we can only disclose those with consent. We are not mandatory reporters under state law, even if we hold a license that says we are mandated reporters. Services are provided at no charge. We're going to take a quick look at what we did in fiscal year 25. We made 3,339 visits in nursing homes, and 247 of the 430 nursing homes had a routine visit each quarter of the fiscal year. Here you can see some of the other work we completed in fiscal year 25, answering questions for long-term care staff, answering questions for other individuals, completed visits to long-term care homes, attending resident or family council meetings, participating in nursing home survey events, and providing community education, and investigating and closing complaints. Our fiscal year 25 complainants, we can see that residents, we had almost 1,500 complaints from residents. Next up would be resident rep, family or friend. And that means almost 90% of the time complaints came from residents, their families, friends, or representatives. We might get complaints from resident family councils, a nursing home's administrator or staff. The ombudsman or volunteer ombudsman may be the complainant, a representative from an outside agency, or a concerned person.
Make her use her PTO time for what she said. I got
What type of concerns do we address? We can help residents with any concern that impacts their health, safety, quality of life, quality of care, or resident rights. Here's our top 10 complaints for fiscal year 25. As you can see, these issues touch so many aspects of a resident's life. The discharge and eviction is normally our top or one of our top complaints. These tend to stay fairly consistent through the years. And I'll let you read a minute for yourself, all of these complaints that we worked on this year. In Michigan and across the nation, ombudsmen work to resolve concerns to the satisfaction of the resident. In Michigan, our goal is to focus on residents' rights, quality of life, and quality of care, support residents in self-advocacy, seek systemic change to improve resident outcomes, and we do this by collaborating with and supporting providers in reaching shared goals, working creatively to be part of the solution, serving as a resource and working with residents, their families, or responsible parties to address resident concerns. Here's how we approach resident concerns. Our ombudsman visits often with residents, and this will result in discussions of unmet or unknown needs or concerns. A local ombudsman will ask the resident how they would like the concern to be investigated and resolved. Remember, we work at the resident's direction. Resident must provide consent for us to speak with staff. We do encourage the resident to self-advocate with our support if it's appropriate and that's something that they want to do. Work with the resident and staff to come to a resolution. And what we're looking for is resident satisfaction. Now that you know about the Ombudsman program, please reach out to the local ombudsman if you have questions or would like to schedule a visit. Our website is another great resource for a variety of information, including fact sheets in multiple languages and an advanced directives booklet. You can look up your local ombudsman by county and see their photo and contact information. And we also have resources on abuse prevention and resident rights. The number you see listed is a geo-routed number. It will go to the ombudsman with the area code that you are calling from. That is the end of our presentation for today. Thanks so much.
Thank you very much. Does anybody have any questions? I see a couple hands up. Again, I don't know if it's left over from the beginning. Renee Parks or Trish, if you have questions, go ahead and ask. I see Trish put her hand down. Renee, we can't hear you if you're talking.
Oh, sorry. Earlier
Nope,
when
fine.
they said raise your hand, if she asked a question, that's when I raised that. I don't have a question. Sorry.
Okay. Oh, no problem. Thank you very much.
Well, I'm glad you've worked with us in the past.
Absolutely. All right. Well, thank you very much. I appreciate we all appreciate your presentation. And I will be able to share your slides with the rest of the group if you send them to me, and I'll put them on our website.
Perfect. And now I just need to figure out how to stop sharing my screen. So I would take your advice on that as well, because when I push share, I don't see a way to stop sharing.
Maybe at top left.
Oh,
there we go.
I think you did that. So I appreciate that. Thank you.
All right. Let me bring mine back up here. We're going to jump around the agenda here a little bit. When we originally had the meeting set up, I had asked, I always ask for agenda items, and a couple of the things that we got back was how do you deal with dementia resident aggression and other resident safety, and what would you like to see in a good fall prevention program with dementia population? And what I did with that is I sent those questions out to all of our surveyors and asked them, you know, what have they seen in facilities that they would consider a good fall prevention, or what have they seen facilities do when it comes to resident aggression with residents with dementia. And I got a bunch of responses back. And actually, at the end of this presentation, I kind of bulletized all the responses that I had. Along with that, I asked if any of the surveyors would be willing to share their observations with the group, and we actually had quite a few that said they would. Unfortunately, we were only able to secure 2 to be able to share with us today. So today we have Scott Nelson and Sean Seeger. Both of them are healthcare surveyors from the Lansing Southwest team, and I would be very happy to allow them to kind of share some of the things that they've seen out in the field with the facility. So I don't know if you guys have set up who wants to talk first, but Scott or Sean, go ahead.
I'll go ahead. I don't see Scott. He might be in there somewhere. Hello, everyone. Thanks for inviting us, Dave. We really appreciate it. A few years ago, I had a conversation with a facility in the Lansing Southwest region that was working with an area university on a sleep study with dementia residents and how it affected the rate of falls. The study showed that waking residents with dementia during the night every 2 hours for the check and change resulted in a higher rate of falls than those that were not woken every 2 hours. According to the long-term care facility, both study teams acknowledge skin integrity as a priority. The facility trialed the use of higher absorbent briefs than their normal briefs, and higher quality came at a monetary cost. This cost difference was absorbed, with every pun intended, in less falls with injuries, as fall injuries cost money. Skin integrity was not compromised during the study with the higher absorbent briefs. So resulting in a win-win situation for the facility and the residents. Preliminary results of the study proved a higher quality life was obtained, including better sleep, less confusion, fewer falls with injuries, and better overall health with less behaviors during the night and the day. The facility went on to explain how the university's research explored how sleep issues in long-term care residents, including poor quality, fragmented sleep, and medication effects, linked to increased fall risks, and developing caregiver education for fall prevention, highlighting sleep disruptions as a key but complex factor in elderly falls. As we all know, long-term residents experience fragmented and poor sleep efficiency. Research confirms poor sleep is common in long-term care and is associated with higher fall rates, with some findings suggesting hypnotics might even reduce falls in frail individuals, but the residual effects of these medications throughout the day led to confusion, behaviors, and increase in falls, while others noted increased risks with sleep problems. The university's research also focused on caregiver education to improve knowledge and practices for preventing falls, recognizing the team approach was needed. Sleep problems are more severe in long-term care than in the community, impacting safety. Poor sleep can mimic dementia symptoms, making assessment crucial. Understanding the interrelationship between sleep medications and falls help develop better care strategies. And from what I understand, talking to the university, because this was something I was really interested in and excited to hear that the facility was doing, is that the university is continuing their their study. You know, of course they do because it's a couple year study, but they had found that the checking and changing during the night did improve, like I said, the overall better health for the resident during the day and with behaviors, but it came at a cost, monetary, for the facility. So they were still trying to figure that part out. So thank you.
Thank you, Sean. Any questions for Sean? All right. I know Scott's on. Scott, do you want to unmute yourself and share some of your observations?
Of course. Hello, everybody. Thanks for having me on here. I appreciate it. So yeah, David laid it out perfectly. He had reached out and we shared some of our observations, best practices that we've seen. And so I was even hesitant in responding because these two topics are so complicated, and everything I would type out, I just kept thinking from the eyes of someone at a facility. They're probably thinking, oh, that's easy for the surveyor to say. So trust me, I understand these are very difficult, and every resident is different, and likely what I'm about to share from what I've observed, you've already done, you're actively doing. So please don't take that as me saying you need to do this or anything like that. These are just some observations at certain times where it's been clear where these best practices have helped. So in the first topic, dementia, a resident with dementia with aggression involving theirs and others' safety. I think what gets missed a lot of the times, or it's just that it's not documented, is implementing meaningful activities. And sometimes you see these people that get labeled as aggressive, but then when you talk to staff, it's not clear why they're aggressive, what time of day, what certain situations. People just get labeled aggressive. And then they'll just say that they wander and are verbally and physically aggressive towards others. But then when you looked at, let's say, a care plan, sometimes there's not person-centered care plans addressing activities. Sometimes it's unclear if a family member has even been reached out to. I mean, the resident, even if they're confused, they could still possibly share. So asking them activities that they'd like. But the one example that really stood out to me, I don't even know how many years ago it was, but the fidget, it was before there was the zipper and the buttons and the clasps and those type of, I don't even want to use the word fidget board, but the activity blankets or boards. A lot of them will look very similar with very similar attachments. But this facility found out this gentleman was a retired mechanic, and they created this very specific, again, I don't know a better word for it and I know there probably is, so don't get upset with me if I'm using the wrong terminology, but a board, and it allowed him to tinker, and it emulated more of a nuts, bolts, like a shop type situation, and it kept him meaningfully engaged. Now, it didn't keep him engaged the entire day that he was awake, but it did keep him engaged. And it was something that he enjoyed, and it was specific to him. And it was safe. Nothing could come off of the board that could harm the resident or others. But I know some people are like, well, that's simple. We always do some interviews to find out activities of what people were interested in before. But it was just a very simple but effective idea that the facility used. And this was definitely a gentleman where there was no rhyme or reason for time of day, or it was just very unpredictable when he would become verbally or physically aggressive towards others. But that was just one intervention, and it all just stems back to meaningful activities. A lot of times care plans will just play music that they like. And again, what kind of music do they like? If I'm the caregiver for that unit and I don't usually work with that resident, I go to that care plan, I would like to know what music to go turn on. Because that is a meaningful activity. Not too long ago, there was a resident who was in some distress, and the aide came in, turned on the music, and it was like a light switch was changed. The person stopped wringing their hands and repeating this similar noise, and they were visibly calm and less distressed, and that was a meaningful activity. And then for the next topic, it was the fall prevention in residents with dementia. Again, a very loaded topic. There's no easy, simple solution to this, as you all know. Sometimes I've noticed there's so much going on with the fall. Every fall, the facility immediately jumps on top of it. It's looking for another intervention to implement to prevent a future fall. But then there's those times where residents are having frequent falls, whether it's something's changed, this wasn't their normal routine of having this many falls. But I feel like time of day gets missed sometimes. And oftentimes, I see it in care plans, people will make notes of times of day for certain things, and that can alert staff to, like, sure, some people wake up all different times of day. You never know when they're going to wake up. Some people, it's like clockwork. And I've noticed when facilities hone in on time of day for people and certain preferences, they're able to be more proactive rather than reactive. So instead of just finding the person on the floor after they've woken up and fallen, they had already previously addressed these patterns of time with having falls, and then they've been able to be proactive and attend to those people's needs before those falls happen. Again, I know those are two very basic, simple observations for the two different topics. But again, being in a lot of different facilities, seeing those things over and over, small things, but meaningful impacts that they can have.
All right.
Thank you,
Thanks,
everybody.
Scott. Thank you so much, Scott. Any questions for Scott? Is there anybody that would like to share something that they do in their facility or some interventions that they've found to be very beneficial in preventing falls, especially with dementia residents
The
or
bathroom. They keep
helping
making
with
the delivery time later and later. So should I just go to the fucking store?
Oh, well, sorry about that. Rated PG show. Where was I? Kind of got off track there. I apologize.
Any best practices?
Yes. Anybody? Anybody want to share some things that they do in their facility? Mrs. Thalen.
As a manager, I just share, and people know this, but it's just to be straightforward. I love the discussion. It's something we deal with every day when we edit reports, when we deal with family complaints. The facilities that are more robust in managing dementia and aggression behaviors are those that have really robust interventions in place as those aggressions take place. Facilities that tend to put so much energy on the front end that the person's aggressive and they have copious amounts of dialogue and documentation about all the extent of the aggression, but then there's a complete void and a complete lack and a complete just not thoroughness on interventions. And when you ask staff, and the answers about aggression are, well, everybody knows they're aggressive, and that's like the end of the story. You tend to struggle more. So as a manager, having done this for many, many years, I encourage everyone to just look at those interventions in place for those dementia aggressive residents, reintroduce things that maybe you didn't work before, reintroduce them again, and just put as much energy in terms of interventions with your staff so that they know that, yes, we know they're aggressive. And here's a whole big toolbox of how we're going to try to manage it. Because as a regulator, when we look at it, your interventions may not be successful, but if they're there, it's a huge step in the right direction in terms of de-escalation with behaviors and negative outcomes. I just want to share that from a perspective of people in the field and reading reports. Thank you. Appreciate the time.
Thank you. Anybody else want to share anything that they do in their facility? Cheryl?
David, may I share a best practice that I've seen in a facility?
Absolutely.
So back in the day when I was still heavily in surveying, I'm Cheryl Howlett. For those who don't know me, I'm a manager of the Lansing Southwest team, the two surveyors who were speaking earlier. Some of the best practices, I couldn't speak higher to what they were talking about when it comes to these activities and the meaningful activities. And so I had surveyed a facility, a few years ago, just a couple, that on a resident that had just so many falls. And we had been in and out of that facility multiple times for this resident with falls. When I came back in 6 months, probably been in there 3 times, a couple other surveyors had been in there. 6 months later, I got a really warm welcome from the director of nursing, who was clearly frustrated with the state agency coming in so often, which I totally understand. We do disrupt your lives heavily when we come in. Began the investigation into a situation, and I was chastised heavily by this director of nursing, which I was very proud of, by the way, by saying that, you guys come in here so much. You've been here so many times. You've cited us so many times for falls. And I just wanted to let you know that we had 25 falls a month before, and now we're down to maybe 2 a month. I'm like, okay, great. What changed? Exactly what the surveyors were speaking of. A meaningful activities for those residents who were at risk, learning those residents, taking the time to be able to really drill down on what they needed to keep them active, to prevent them from wanting to get up and go places. They're no longer sitting at the nurse's station or sitting in their room. And so, while the DON was at the moment just frustrated because we're back in the building and I was heavily chastised for being back in there, I was also grateful to hear that they were able to implement changes in their falls program that was meaningful for the residents and impacted both the residents and the facility staff, because now they're not having to deal with those falls and constantly writing up IA reports and doing investigations and reporting to the state agencies if they feel it's necessary, and all of the things that go with the falls. It just minimized so much work for them by decreasing the quantity that they had in their building. And so, while I know we're difficult when we come in, and sometimes it's just hard to stomach that we're back, sometimes we can help you make a difference and impact your facility in a positive way. And it's good to hear that the surveyors, even to this day, it's been 15 years, are still seeing the same thing out there, that those meaningful activities really do make a difference for the residents and the facilities at the same time. Thank you, David.
Thank you. All right, we'll get back onto our agenda. I know we're running a little bit short on time. I'll try to go through this a little bit quick. All right, so just a kind of a couple updates here. I'm sure a lot of you have been made aware that via the email, that the email that comes automatically from MyFry's changed a little bit. Due to updates to Chapter 5 by CMS, all incidents that are reported by facilities now need to go into the CMS database. Previously, we did not have to put those we didn't have to put every single one in. We could review something, and if we weren't going to investigate, we could close it out and make the facilities aware. With the updates to Chapter 5, now all of the incidents that we get in MyFry go into iKeys. They go through the same process that any other intake would go through, where they're input, they are reviewed, they're provided a priority level, and then the state agency will act upon them per Chapter 5 and CMS guidelines. So you'll no longer be getting the emails that say that it's been administratively reviewed and closed. So they will show up closed in the MyFry system, because that's just the process that we have. Is once we put that into iKeys, it's closed out in MyFry. But that doesn't necessarily mean that it's closed because of administrative review. We're no longer doing that. And I kind of put in what the verbiage of the new email says there on the slide. Another reminder with my login is if you have to make sure you log into MyFry at least every 60 days. What we're doing is every second week of the month, we're running a report to see who has not had logins. And then we're sending emails as reminders. So you'll get an email that says action required. You haven't logged into MyFry within 60 days. So please log in. You don't have to do anything. You just have to log in. You don't have to submit anything. You just have to simply log into MyFry, and that restarts the clock. So if you get the email, please be sure to log in, and that'll reset the clock. One of the questions that came forward when I requested agenda items was, how is the annual fire marshal? How is the annual fire marshal inspections going to be billed? And so that's the $5 per bed charge that's going to be responsible for the fire marshal inspections. And the latest information that we've been provided is that providers will receive an invoice in April for that charge. Just a reminder, again, please make sure you read your notices after survey. Lots of good information in there. All the contact information that you need to have for health and life safety code are in there. And just a reminder that the health safety code, or health safety and life safety code, oh my gosh, health and life safety code are two separate entities, and they're managed by two different sections. So if you have a life safety code question or concern, please make sure you reach out to that individual or those individuals that's on your notice. Another update, we are planning on doing a social work boot camp towards the end of March. And what this is going to be is there's a group of social workers, both social workers that are currently working in facilities, social workers that are part of the ombudsman program, and social workers that are state surveyors. And we're coming together to create a mini boot camp, which is basically going to be geared towards newer social workers in facilities to kind of give them tools that they need to be able to perform their duties in the facility. I am going to be sending out a quick questionnaire / survey to kind of gauge interest in who would be, what facilities would be sending their social workers to for in person. It'll be in person, but it'll also be available via the web. So it's not mandatory to get you won't have to be in person to get the information, but we are offering it in person as well. So that will come out here shortly. I just kind of wanted to make you aware real quick. Oops, I guess I got that on there twice. Another reminder for iKeys. iKeys is another one of those where you have to log in every 60 days. So even if you don't have notices or plans of correction or everything, if you can set up a reminder in your calendar to log in, that would be very beneficial. What happens is we're finding that we have facilities, we'll do the recertification survey. 6 months later, we'll have a complaint survey and they don't have an EPOC user. And basically what happens is somebody at the facility then has to go through the process again of getting access to iKeys. So just a simple calendar reminder to log in would be helpful. There has been a request to CMS and to iKeys to send out notices to those users who are coming up on 60 days. And supposedly they're supposed to be working on that. So hopefully we will see that. With that is, if you do have issues with iKeys, at the bottom of the iKey, if you go to the iKeys website, at the very bottom of it, has all the information for help and support. It's got the email, it's got a link, it's got the phone numbers, and it also has the hours. So that's that information is there for you to get help with if you do need help with iKeys. I do see there's some things in the chat. Question, when will MyFry update showing survey is complete in the iKeys column of the MyFry status? If you could send me particulars on that, I can take a look. Yeah, so there's you won't see anything in iKeys regarding MyFries either. It's the same as if we get a complaint, it's the same process as that. The complaint goes into iKeys. There's no tracking of the MyFries outside of what's in MyFry. So again, you know, the fry comes in, the incident comes in, we review it, we wait for the investigation, or we prioritize it at the time of the incident. Once the investigations come in, that whole file basically goes into iKeys and then is handled per Chapter 5, just like a complaint would be handled. Somebody asked, I thought with iKeys we didn't have to do that anymore. I don't know if that's the every 60 days, but definitely have to, if you don't log in within 60 days, your account gets rejected. No, if it's closed in MyFry, it is not considered a desk review. There's no more desk reviewing MyFries. All MyFries will go into the iKey system and they be processed per Chapter 5, which indicates that they need to be put into the system, reviewed, triaged, and then acted on appropriately according to the priority level of what's been triaged. All right, Jessica, I hate to do this to you, but we're going to go ahead and jump into the updates to the IDR and IIDR process. Jessica Maurer, go ahead.
Hi, should be quick. I'm Jessica Maurer. I'm the Quality Section Manager for the Bureau of Survey and Certification. My contact information is there. Right on this presentation, if you click on IDR and IIDR processes, it will take you to our website. I would love for you all to bookmark it. It is the most up-to-date information on IDR/IIDR. You can go to the next slide. So there is no process change. The only thing that has changed is the request form for both IDR and IIDR requests on that website. The request form links are marked accordingly. So when you are submitting an IDR or IIDR request into the Improve portal, a request form is required. It must be filled out completely. Otherwise, if we don't get that completely from you within your required time frame, you will waive your right to IDR or IIDR. So the forms have changed just a little bit. We now require a code to be entered in for each tag you are disputing to explain your primary reason for the dispute. And that is just because really following Chapter 7 of the State Operations Manual, we have kind of changed our process in recent years to go right from Chapter 7. We got rid of some of the things that were happening before we adhered strictly to Chapter 7 of the SOM. And then the other thing I wanted to mention was that if you are having difficulty with the Improve portal, please immediately call the Improve contacts. They're on the IDR and IIDR request forms. The phone numbers are, it's on our webpage. There are various ways for you to get those numbers. And they have a call log. So if they log that you called, then I will know that you are trying to troubleshoot things from the very beginning. And we can work with you if, you know, you're past your due date, but you are trying to troubleshoot issues. So I really recommend you call them, contact them immediately if you're having portal issues. And then my last slide is the next one, and it's just kind of, I don't know if you can see it really well. I just kind of took a screenshot of how the request forms changed. And kind of at the bottom there is where you put your reason for your disputes. And that is it from me, if no one has any questions.
Thanks, Jessica. Any questions for Jessica? All right. Any questions in general? I see there's a couple more things popped up in the chat. Are they done setting up EPOC and IKEYs? Yes, that's EPOC and IKEYs has been set up since the since July 14th. It says my past surveys still aren't showing up correctly. If you want to reach out with specifics on that and screenshots, we can try to help you out with that. How do we know if a MyFri is closed or resolved satisfactorily? I guess the short answer is there's really no, it's just a reporting mechanism that the facilities use to show an incident, to let us know of an incident in the investigation that took place. And hopefully the follow-up or another question that was on here, it says, will all FRIs need to have an on-site visit, or will administrative review still be able to be completed? So with any allegation that comes forward towards a facility, the state agency does have the ability to do an administrative review and not have to do an on-site visit for any allegation. So yes, the MyFris, there will be times where incidents will be entered into IKEYs, and when it's reviewed by the manager, it'll be administratively closed out in IKEYs. I know we're down to 1 minute, but does anybody have any questions? I am not seeing anything. I want to thank everybody for your participation. This is the recording and the PowerPoints will be available on our website. Hopefully by the end of the week, no promises, but I'll get them up there as soon as I can. So again, thank you. I hope you found this informative, and we will look forward to seeing you the next time. Hope everybody has a good evening.